Hello friends, today we shall be discussing about PTH, Calcitonin, PTHrP and CGRP, and my name is Santosh Abraham. I'm working as a specialist registrar in diabetes and endocrinology at Scarborough General Hospital. Today we shall cover the following topics: PTH, its regulation, calcium sensing receptor, the CASR protein, PTH metabolism, effects of PTH on kidney and bone, and then calcitonin, PTHrP, CGRP and related peptides. Coming to the regulation of PTH secretion, the major regulator is ionized calcium in blood. If there is increased ionized calcium, it leads to a decreased PTH secretion, and the shape of the dose response curve is sigmoid. PTH levels briefly rise during a sudden drop in blood calcium than they do during a more gradual fall in calcium. You should always remember that. So this property offers an additional protection against sudden hypocalcemia. So the level of change in PTH, the rate in which the PTH levels change is more abrupt in hypocalcemia rather than hypercalcemia. The dose response curve of PTH is as follows with response to the ionized calcium. A represents the maximum secretory rate, and B is the midpoint of the slope of the curve and and C is called the set point. That is the level of the calcium at the midpoint of the slope, and D is called the minimal secretory rate. So this curve is a sigmoid shaped curve, and as you can see, when the calcium is dropping, at the level of 1.3 or 1.4, something like that, there is a sudden rise in PTH, and below 1 it is approximately reaching the peak. Whereas PTH suppression, when there is hypercalcemia or when the calcium is going towards the upper side, is almost flat. Now, characteristics of the dose response curve. The minimal secretory rate is low, but as you can see, it is not zero. It is low, but it's not zero for any given levels of calcium above the normal limits. An increased serum iron calcium leads to a decrease in PTH secretion, and the maximal secretory rate represents the reserve of the parathyroid's capacity to respond to hypocalcemia. So A represents the maximal secretory rate, so it's the PTH reserve actually. And because the values from normal persons in the steady state are located in the lower portion of the sigmoid curve, the system seems designed to respond more dramatically to hypocalcemia than to hypercalcemia. Calcium sensing receptor on the parathyroid cells is a G protein. So inactivating mutations cause familial hypocalciuric hypercalcemia, and activating mutations cause familial hypoparathyroidism with hypercalciuria. CSR is widely expressed. and it is expressed in renal tubules and also in the calcitonin producing cells of the thyroid. And this CSR contributes to the calcium homeostasis. It's also expressed in organs such as the brain, and it could point to different roles of calcium signaling in the CNS. Regulation of the parathyroid hormone gene. Now, the minute-to-minute regulation of PTH can be explained by two mechanisms. One is regulation of PTH secretion by the CSR alone, and two is the amplification of this regulation by intracellular degradation of stored hormone. That is, when the CSR senses the calcium, the PTH will start falling, and this fall could be is amplified by the intracellular degradation of PTH. Acute hypocalcemia in an hour leads to an increase in PTH mRNA, whereas hypercalcemia leads to little or no change in PTH mRNA. So that's why you can see that when you go towards the slope, when you go towards the dose response curve, when there is a fall in calcium, especially when there is an acute fall in calcium, you can see the PTH levels massively going up. The mechanism for the increase in PTH regulation at the levels of happen at the mechanism for increase in PTH happens at the regulation at the levels of regulation of gene transcription, mRNA translation, mRNA stability. So the gene transcription, mRNA translation, mRNA stability primarily dictates how the PTH will rise when there is hypocalcemia. PIN1 and KSRP, it destabilizes PTH mRNA. In chronic kidney disease, when there is hypocalcemia, low levels of PIN1 are found, and this raises PTH mRNA, and hence the PTH production will be increased. And what are the effects of phosphate? Phosphate elevation stimulates PTH secretion because it lowers calcitriol levels. But phosphate can also increase PTH secretion directly, independent of blood calcium and vitamin D3. So that's the recent finding. And phosphate increases PTH secretion acutely after a small delay, and probably works largely through the regulation of PTH mRNA levels. So phosphate also works through the regulation of the PTH mRNA levels, whereas calcium will work at three levels: gene transcription, mRNA translation, and mRNA stability. FGF23 is an important phosphate regulating hormone, and it activates the FGF1 receptor. The co-receptor is called Klotho, and it activates FGF1 and FGF1 receptor 1 and Klotho on parathyroid cells, and this decreases the PTH levels. In renal failure, both FGF23 and PTH levels are elevated. So you might wonder why, when the FGF23 is elevated, why the PTH is also getting elevated. This is because there is downregulation of parathyroid FGF1 receptor 1 and Klotho in renal failure. So even if the FGF23 is elevated, it cannot act on the FGF1 receptor, and hence it cannot suppress the PTH synthesis. So even though the FGF23 is elevated, the PTH also will get elevated because it cannot act on the receptor. Role of vitamin D: there is no direct effect on PTH secretion, but it dramatically suppresses PTH gene transcription, and it does not occur when calcitriol is administered to chronic hypocalcemia, because hypocalcemia leads to a fall in the parathyroid vitamin D receptors, or the VDRs, or because hypocalcemia can increase the expression of calreticulin. So in short, there is no direct effect, but it could decrease the PTH gene transcription in a drastic way, and it does not happen when the vitamin D levels is low, when there is hypocalcemia and when vitamin D is administered. So regulation of parathyroid hormone parathyroid cell number. Calcium, when it acts through the parathyroid CASR, it will restrain parathyroid proliferation, that will inhibit parathyroid proliferation. When CASR is absent, large diffusely hypoplastic cells are formed because of the insufficient activation of parathyroid CASR by calcium. The role of vitamin D in the regulation of cell number is less established. Renal failure can activate mTOR C1 complex, and this increased signaling by mTOR1 is required for the parathyroid cell proliferation. And this increased signaling causes the parathyroid cell to proliferate. So in renal failure due to the mTOR C1, you can see that large number of parathyroid cells are formed. Now PTH, secreted intact PTH, is extensively metabolized by liver, 70%, and a minor fraction is metabolized by the kidney, and it disappears from the circulation with a half-life of 2 minutes. That's why after parathyroidectomy you measure the level of PTH to ensure that the parathyroidectomy is successful, because you can easily find out the pre-operative levels and the post-operative levels, and you can find the difference, and you can ensure that the parathyroid hormone is no longer present. This rapid peripheral metabolism of PTH is unaffected by blood calcium or by the by calcitriol, and less than 1% of the PTH will bind with the PTH receptors or on the physiologic target organs. And these features of PTH metabolism ensure that the blood level of PTH is determined principally by the activity of parathyroid glands, and that the PTH level can respond rapidly to small changes in the rate of secretion of hormone. So as I've already told you before, it has the dose response curve has a sigmoid pattern, and the PTH levels change drastically in response to hypocalcemia than hypercalcemia. So because of the small half-life and because of the very small amount of total secreted PTH that is binding to the target organs, the blood level of PTH is determined by the activity of the parathyroid glands, and because of all these, the PTH level can respond rapidly to smaller changes. Coming to calcium reabsorption, almost all of the calcium in the initial glomerular filtrate is reabsorbed by renal tubules. More than 65% takes in the proximal tubules via passive paracellular route, and rate of sodium reabsorption controls the rate of calcium transport in the proximal tubules, and PTH has no effect in the proximal tubules. So you have to remember that PTH does not affect the 65% reabsorption in the proximal tubules. 20% is absorbed in the thick ascending loop of Henle, that is in the cortex, and 10% in the DCT and the CT. In the thick ascending loop of Henle, calcium reabsorption also is mainly passive and paracellular and requires expression of paracellin, that's a unique tight junction protein, and mutant paracellin can cause renal calcium wasting and magnesium wasting disorder. And this paracellular calcium transport in the CTAL is influenced by the positive transepithelial voltage gradient, and it is established by the active sodium potassium chloride reabsorption transporter. So calcium reabsorption is strongly inhibited by loop diuretics in the CTAL, such as furosemide. The CASR is expressed in the CTAL. You have to remember that the CASR is expressed in the thick ascending loop of Henle, and when it is activated by high blood calcium or magnesium, this receptor inhibits this sodium potassium chloride transporter, and then it inhibits the calcium reabsorption in the fetal. So these are all parathyroid independent mechanisms for controlling renal calcium handling in response to changes in the blood calcium. Now the PTH, so as you have seen from the both the previous two slides, we can infer that then the PTH will be acting on the distal tubule and the collecting ducts and the collecting tubule. So now we come to the actions of PTH. So it stimulates calcium reabsorption from the kidneys, but from the distal tubules and the proximal and the distal convoluted tubules and the collecting tubules, and it inhibits phosphate transport. There are other renal effects which we shall discuss. It increases bone formation, and it also increases bone resorption. So this is something different from the previous lecture, where the basics of calcium metabolism was discussed. So the PTH mainly affects on the distal nephron calcium reabsorption. The primary site for PTH is the distal nephron with regards to renal calcium reabsorption, and the distal nephron will normally reabsorb the remaining 10% of the filtered calcium. It is done by a transcellular active transport mechanism, and PTH will stimulate the distal convoluted tubule and the collecting tubule active calcium transport by upregulating TRP V5, calbindin, and NCX1 directly and indirectly, and also it increase and also there is increased synthesis of 125 hydroxy vitamin D2. So the main action is through the TRP V5. So it acutely increases the flux of calcium through the TRP V5 through its increased recruitment and expression. And what happens to phosphate? Phosphate reabsorption mainly occurs in the proximal renal tubules. So 80% is reabsorbed there. Some additional phosphate is reabsorbed in the distal tubule, 8 to 10%, but not in the loop of Henle as compared with the calcium. So there is 10 to 12% which is excreted in the urine, the remaining 10 to 12%. So overall fractional tubular reabsorption of phosphate is 80 plus 10, so almost around 90%. And what does PTH do in case of phosphate? Phosphate reabsorption in both proximal and distal tubules is strongly inhibited by PTH, and the proximal effect is more important, because here most of the calcium is absorbed. So when it acts on the proximal tubule, it becomes more important, and phosphate is reabsorbed transepithelially, and transport from the glomerular filtrate to cell is mediated by a sodium phosphate co-transporter. The half-life of this transporter is very less, and PTH decreases the Vmax of the transporter, and this is how the phosphate absorption falls markedly. So this is different to how it increases the calcium reabsorption. It is mainly by the TRPV5 and calbindin, whereas in phosphate it is by decreasing the Vmax of sodium phosphate co-transporter. And the way PTH, how it does is through cyclic AMP and protein kinase A. And if the dietary intake of phosphate is increased, there is increased expression of sodium phosphate. Sorry, there is decreased expression of sodium phosphate co-transporter, and vice versa. If you have decreased dietary intake of phosphate, the expression of sodium phosphate co-transporter increases. So this is and this is actually a PTH independent mechanism. That is, this depends on the dietary intake of phosphate, and it is mediated by the PGF23. So So depending on the phosphate dietary intake also, the phosphate reabsorption can be controlled. But the most important factor is PTH again, because whenever the PTH is high, actually whenever the phosphate, even if it is normal, if there is increased PTH, what it does is that it always decreases the Vmax of the sodium phosphate co-transporter. Since sodium phosphate co-transporter has a small T-half, it is rapidly sequestered. But phosphate reabsorption is also regulated by the dietary intake, and that's independent of the PTH mechanism. So the PTH actually plays a role in the normal circumstances, and also in conditions where there is less PTH or increased PTH. And the other renal effects of parathyroid hormone are: it stimulates the synthesis of 125 hydroxy D2 in the proximal tubule by rapidly inducing transcription of 25 hydroxy D2, 25 hydroxy D 1 alpha hydroxylase genes. So PTH will stimulate the 1 alpha hydroxylase genes, so it will produce the calcitriol. And PTH inhibits proximal tubular sodium, water and bicarbonate reabsorption by inhibiting apical sodium hydrogen exchange and the basolateral sodium potassium ATPase. So it will also inhibit tubular sodium, water and bicarbonate reabsorption. PTH also, so it could have a mild diuretic effect in that sense, and PTH also stimulates proximal tubular gluconeogenesis, and it also acts on the podocytes of glomerular basement membrane, and to decrease the GFR of single nephron and the whole kidney. What is the action on bone? So it is very complicated. It acts on a number of cell types, both directly and indirectly. So for many years, the release of calcium from bone was thought through the stimulation of bone resorption has been considered to be the major action of PTH on bone. But this is only part of the story. In fact, PTH administration by any route increases both bone resorption by increasing the osteoclast number and also bone formation by increasing osteoblast number. So this is something very different from what we have learned from a medical school. So it increases both the osteoclast and the osteoblast, thereby increasing the bone resorption and the bone formation respectively. So which action dominates depends on the dose of PTH and the route of administration. So if the PTH is continuously administered, the effect of PTH on bone resorption dominates, and the net result is release of calcium from bone and decrease in bone mass. So this can be seen in primary hyperparathyroidism. In similar fashion, if you administer Rankal, it also increases the osteoclast number. That is in a continuous fashion. But if you give PTH intermittently, administration of low dose of PTH or active fragments of PTH by once daily subcutaneous injection leads to a net increase in bone mass with only transient effects on blood calcium. And also when PTH is administered in vivo, whether administered continuously or intermittently, increased osteoblast number and surface and number are noticed, and it results in an increased bone formation rate. Also, PTH increases the number and rate of differentiation of early osteoblast precursors. In short, there is increased bone formation in the midst of resorption when there is increased PTH. So PTH converts bone lining cells to active osteoblasts, and there is decreased rate of osteoblast apoptosis after intermittent PTH administration. And the PTH stimulation of osteoblasts leads to growth factor release such as IGF-1, FGF2 and amphireglin, and it also decreases the synthesis of DCOP-180 and sclerostin, which are inhibitors of WNT signaling, and there is increased bone formation in the midst of resorption. Also, PTH increases bone resorption. Osteoclasts, they don't have the PTH receptors, but osteoblasts or cells of the osteoblast lineage, they include the pre-osteoblasts, osteoblasts, and the osteocytes. They signal to osteoclast precursors to cause them to fuse and form mature osteoclasts when when they are stimulated by PTH. And this signaling also serves to stimulate mature osteoclasts to resorb bone and to avoid apoptosis. So it will increase the survival of mature osteoclasts. Coming to rank and macrophage colony stimulating factor. So these two cell surface proteins, M-CSF and RANKL, are essential for the stimulation of osteoclastogenesis, or for the stimulation of osteoclasts and osteoclastogenesis. And RANKL is essential for the activation of mature osteoclasts. PTH PTH will stimulate the M-CSF formation, and osteoprotogerin inhibits the binding of RANKL to RANK. PTH decreases the synthesis and secretion of OPG, and thus PTH indirectly increases the RANK activity. So increasing the RANK activity, increasing the M-CSF, it will stimulate the osteoclasts formation. And activation of PTH receptors will also cause release of calcium from bone, and it is less understood. So it's usually called the osteocytic osteolysis, but the mechanism is not very well understood. Calcitonin. So in the importance of calcitonin in human calcium homeostasis, it remains uncertain up till now. So it is found in non-follicular cells of the thyroid called the C cells, and these C cells originate from neural crest. It is a 32 amino acid polypeptide, and the human calcitonin gene is located on the short arm of chromosome 11. And the mRNA encoding calcitonin is derived by splicing together the first 4 exons of this gene. How is calcitonin regulated? I mean the secretion. There is a linear relationship between the secretion of calcitonin and the ambient calcium levels. So, and the CASR expressed in the C cells contribute to the regulation of calcitonin secretion. And other calcitonin secretagogues include glucocorticoids, CGRP, glucagon, enteroglucagon, gastrin, etc. Secretion of calcitonin is inhibited by somatostatin, whereas these all will increase the calcitonin secretion. And also when the calcium is increased, there is increased CASR expression, and that will also increase the calcitonin secretion. And vitamin D decreases calcitonin mRNA levels by a transcriptional mechanism. Acute effects of calcitonin. When administered acutely, decreases tubular resorption of calcium and impairs osteoclast mediated bone resorption by a direct action on osteoclasts. So this results in increased rate of bone formation. The physiological role in humans is not very clear. The effect of calcitonin on bone density was examined in patients with long-term hypercalcitoninemia secondary to MCT, the medullary carcinoma of thyroid, and in patients with subtotal thyroidectomy when there is lack of calcitonin secretion. And the abnormal calcitonin levels were found to have no influence in the bone density at the lumbar spine and the distal radius. And also long-term high-dose administration of exogenous calcitonin caused no physiological abnormalities. Coming to PTHrP, so parathyroid hormone-related protein contributes to humoral hypercalcemia of malignancy. So unlike PTH, it is made by a wide variety of tissues, where the PTH is usually made by the parathyroid glands. And it acts locally in ways that may have little relevance to the control of blood calcium. So it has got a strong paracrine effect in the cells which it is secreted, paracrine as well as autocrine. And 8 or 9 of the first 13 residues of the PTHrP are identical to those identical to the PTH sequences, mammalian PTH sequences. So that is how the PTHrP will mimic the PTH action. conserved sequences and PTH displacement. So the sequences in the PTH, especially 14 to 34, are highly conserved, and even though these sequences have little resemblance with the corresponding region of the PTH, they can displace the PTH from the PTHrP receptor, and the remaining, and so it can cause the PTH like activity by this displacement, and the remaining portion of the PTHrP molecule bears no resemblance to the corresponding sequences in PTH. And PTHrP acts as a hormone. It is secreted from the tumor into the bloodstream. When it is secreted from the tumor, it acts like a hormone because it's secreted in the bloodstream, and then it acts on the bone and kidney to raise blood calcium levels. And it also contributes to the cachexia seen in cancer patients because it stimulates the brown fat formation. It stimulates the browning of adipocytes. And PTHrP, it acts as a calciotropic hormone during fetal life. See that, this is very important, and in lactation. So it increases the placental calcium transport, actually, the PTHrP. And secretion of PTHrP from breast into blood stream leads to an increase in bone resorption. So this could explain why you have increased bone loss during lactation. And calcium then activates the CASR in brain. So why you need the increased calcium here due to the PTHrP? Because this calcium will activate the CASR in the breast tissue, and there is increased movement of calcium into milk, and then it will downregulate, and this calcium will auto downregulate the expression of PTHrP in the breast. So it acts like a closed loop. So secretion of PTHrP will increase bone resorption because it will cause more calcium to come out of the bone, but the calcium will activate the CASR, and this will downregulate the PTHrP in the breast. So there is a dramatic but reversible bone loss during lactation in humans because the developing child needs the calcium, and it is mainly taken with the help of PTHrP from the bone of the mother. And you can see that this reversible loss is only minimally affected by calcium supplementation. Even if you supplement calcium during the lactation, this is not reversed. This bone loss is not, this calcium loss is not reversed, actually. And what are the paracrine effects on bone dynamics, and also how it is expressed in malignancies? So most of the actions of PTHrP are due to the paracrine or autocrine effects. It is synthesized at one time or another during fetal life in virtually every tissue, and it has got an important role in the development of fetal bone. And it normally keeps chondrocytes proliferating in orderly columns, and thereby delaying chondrocyte differentiation. So it keeps that orderly column, or the order of proliferation of chondrocytes, and it blocks MEF2 and RUNX2 transcription factors to activate chondrocyte differentiation by class 2 histone deacetylase. And the widespread expression of PTHrP in fetal life probably underlies the expression of PTHrP in wide variety of malignancies. So there is a reinitiation of a fetal pattern of gene expression in these malignancies. So you can see that most of these malignancies will have the fetal cells, and since PTHrP is expressed widely in fetal life, that's how the PTHrP gets the levels of PTHrP gets raised in malignancies or tumors. And PTHrP will also has effects on hair, skin, muscles, and the CNS. In skin, hair, and breast, it regulates cell proliferation, differentiation. In the smooth muscle of the blood vessels, it is synthesized in response to stretch. The same in GIT, uterus, and bladder. And it acts in a autocrine fashion to relax the smooth muscle. It's widely expressed in neurons of the CNS, and it may protect neurons from excitotoxicity by decreasing the flux through VGCC, the voltage gated calcium channels. And it also plays a role in smooth muscle relaxation, because when the transport of calcium across the VGCC is decreased, it could help in relaxing the smooth muscles. Now coming to the calcitonin family, we will analyze calcitonin gene related peptide, the CGRP, then amylin, adrenomedullin, calcitonin receptor stimulating peptides, the CRSP, and the Intermedin. So calcitonin gene related peptide is thought to act as a neurotransmitter and a vasodilator more than a hormone, and inhibition of the CGRP receptors is found in migraines. So there is increased frequency of migraines. It plays an important role in sensory and integrative motor functions. Coming to amylin, it's a highly homologous to CGRP and calcitonin, and presence of amylin in the pancreas of patients with type 2 diabetes mellitus suggests an etiological role for this peptide. But amylin because amylin slows the gastric emptying, promoting satiety and attenuating the postprandial rise in glucagon. So analogs of this peptide are used for the type 2 diabetes mellitus treatment, and also it's being investigated for obesity treatment as well. Amylin will inhibit the bone loss associated with ovarectomy. Coming to the CRSPs, there are 3 structurally related peptides. It's been isolated with the porcine brain, so it is expressed in the thyroid gland, actually, these CRSPs. CRSP is 60% homologous to alpha CGRP, and it binds to the calcitonin receptor, and in a dose dependent fashion it stimulates cyclic AMP production and inhibits osteoclastogenesis. So like calcitonin, it results in a decrease in serum calcium when it is administered, and the receptors for CRSP2 and CRSP3 are not identified. Adrenomedullin is another member of this class, and it causes vasodilatation. It does not inhibit osteoclast activity or formation, unlike other members. And RAM2 regulates the binding of adrenomedullin to its receptor, and RAM2 insufficiency has been found to result in hyperprolactinemia and decreased bone mineral density. And Intermedin is expressed primarily in the pituitary and gastrointestinal tract, and it signals through CGRP receptors and competes with the CGRP for receptor binding. It is a non-selective agonist for the RAM core receptors, unlike the CGRP and adrenomedullin.